Bismillahirrahmanirrahim. Quote of the day, and do good indeed, Allah love the doer of good. Today the topic of presentation is level of healthcare system in Pakistan. I am Dr. Rabbia Iqbal, PGR Community Medicine, and I am presenting under the supervision of Professor Dr. Saira Afzal, Institute of Public Health, Lahore. Learning objectives of today's presentation is introduction to healthcare system in Pakistan, mixed healthcare system, which is public and market system structure and services of primary, secondary, and tertiary healthcare facilities, challenges faced at various level of healthcare system, devolution of healthcare, 18 constitutional amendment, health and population department, recent advances, and MCQs. Learning outcome: by the end of this presentation, participant will be able to understand healthcare system in Pakistan, the structure and services of primary, secondary, and tertiary health facilities, difference between BHU, RSC, THU, and tertiary care hospitals, challenges faced at the various level of healthcare system. Introduction: health system is defined as all the organization, institution, resources, and people whose primary purpose is to improve, maintain, or restore health. Healthcare system is defined as the organized delivery of medical services to diagnose and treat and manage illness. Health system in Pakistan much broader than healthcare system. A health system include everything that influence the health of the people in a country, not just the hospital, doctor, but also policies, financing, workforce, emergency services, medicine, public health program, and regulation. Pakistan has mixed healthcare system, which mean both government and the private sectors. This is the framework of health system, which include these building block: services delivery, leadership and governance, financing, health product, vaccine and technologies, health workforces and information, which provide safety, equality, coverage, and access, and outcome become improved efficiency, social and financial risk protection, improved level and equity of health responsiveness. This is the diagram showing the healthcare delivery system of Pakistan, which include public and private sector. Public sector include federal and provisional government. Federal government include Ministry of Defense and ministries. Ministry of Defense include military hospital and cantonment borders, whereas ministries include research institute, hospital, vertical programs. Provincial government include provincial department of health, which include primary, secondary, and tertiary care, and other is the private sector, which include major hospital, delivery practicing GPs, Hakim, homeopathics, NGOs, philanthropic organization, and traditional healers. In Pakistan, many agencies are delivering health agencies that finance and deliver services for defined population and have mutually exclusive governance and financing arrangement are referred as a vertical system. Other two systems are mixed and horizontal system. Vertical system include armed force health system, Fauji Foundation system, employee social security system. Two horizontal systems include Pakistan Autonomous Quasi-State Organization, Pakistan Corporate / Commercial Organization. These two finance system either by pooling for risk through insurance or by reimbursing provider for service rendered. These three vertical and two horizontal health systems almost fully cover 26.01 million population, which includes 16.59%. Mixed health system play a role by the public and the private provider. This system provides 15.22 million employees of the government and member of judiciary and legislature. It covers 41.73 million or 26.62 of the country's population. Remaining 73.38 of the population is not fully covered for health and seek care by making out of the pocket expenditure in mixed health system. Yeah, this is a diagram of Pakistan health system. These light blue vertical line shows vertical system, which shows armed system, which is 4.01, Fauji Foundation system, which is 5.8%, and ESI, which is 4.39%. Include revenues for profit from commercial activities, predeterminant for philanthropy. These dark green lines the horizontal system, which is private employees, which is 0.64%, and autonomous agencies, which is 1.74%. These light blue shows the mixed health system, which include three-tier public health system, market system, which include revenues, out-of-pocket payments, development assistance, and philanthropy. Next is what is mixed health system. Mixed health system is defined as a health system in which out-of-pocket expenditure, payment, and market provision of services predominate as a mean of financing and provide services respectively in an environment where publicly financed government health delivery coexists with privately financed market delivery. Um, First is market system characterized by the diverse range of non-state actors exist along with the public system in Pakistan and play a dominant role in providing healthcare. This system is heterogeneous in terms of qualification of healthcare providers. The system of medicine followed status of registration of providers and duration of their practice. In terms of qualification, non-state providers range from doctors possessing medical degrees to formally trained allied health professionals such as midwives, DIs, TBS, LHVs, LSWs. Untrained health providers include paramedics and laboratory technicians. Market system include for-profit healthcare sector. A range of private sector healthcare facilities also characterize the market system. For-profit healthcare sector include ambulatory clinic operated by the general practitioner and specialist maternity home, private dispensaries, diagnostic facilities, and private hospitals. Generally, these infrastructure is concentrated in major population center. Number B is the non-profit healthcare sector, which comprises many NGOs and charitable and trust-funded organizations. The AD Foundation, which is the largest and the most effective functioning ambulance network, is owned by the charitable trust. Rehnuma, uh, which is traditionally play a significant role in delivering family planning and services in Pakistan. Many NGOs are working actively in areas of HIV and AIDS due to the availability of funds. Number second is the public system. It is a strong post-colonial imprint with the National Health Service model operating albeit and several gaps, revenues and development assistance finance. The public system or the state's health infrastructure, it comprises of national public health program, set of disease, specifically federally led public health program, for example, HIV, AIDS, malaria, tuberculosis, and hepatitis program. And second is the three tier of service delivery, which is primary, secondary, and tertiary. This is the statics of the private healthcare delivery system. More for profit, a diverse group of doctor, nurse, pharmaceutical, traditional healer, drug vendor, laboratory technicians, shopkeepers, and unqualified practitioner. And for non-profit, around 3,000 NGOs registered under the various act and working in the health sector. Private sector includes 125 large hospital, 425 small hospital, 97,500 clinics, 6,500 dental clinics, 62,500 hakims, 1,59,000 homeopathic practitioners. Public health delivery system include these 92,000 LSW, 441 TB centers, 5,671 dispensaries, 5,527 BHU, 747 MHC centers, 686 RHCs, 1,279 hospitals, and total hospital beds are 1,32,227 beds. This is the National Medical Establishment Pakistan Economic Survey in 2019 to 2020. Next is the service delivery challenge in Pakistan. In mixed system, Pakistan has many islands of excellence and numerous professionals of high repute and integrity. However, insufficiencies and malpractitioner are wide prevalent and act as a major barrier in improving health services and system. These malpractices include self-abstinence, self-abstinence, dual job holding, theft of supplies, procurement dispensaries, unethical behavior and indifferent attitudes of staff in service delivery and patient. The next topic is level of healthcare system. This is the first level is the primary level, which is the basic health service and preventive care. Second is the secondary care, which is the specialist and diagnostic services. Third is the tertiary care, which is the highly specialized and complex medical treatment. Number one is primary health care. Primary health care is the entry point into the health system for most of the people in Pakistan. It is community based and emphasizes accessibility, prevention, and continuity of care. This level is responsible for addressing the most common health need of the population and preventing disease before they become severe. Services are typically delivered close to the people's home, especially in rural and peri-urban areas. Primary health include basic health unit, rural health center, dispensaries, and lady health worker programs. Basic health unit are represent the most peripheral fixed health facility. They are designed to decentralize the service delivery and bring essential health services closer to the community, particularly in rural and underserved areas. BHU cover almost 10,000 to 25,000 people. Its coverage varies by province and geography. It has no inpatient bed, but some upgraded BHUs have 2 to 5 observation beds. Staff include one MO, one WMO, one dispenser, one daily head worker, midwife, and supporting staff. Functions of BHUs: outpatient care for illness, common illness, maternal and child health services, immunization and family planning, basic laboratory tests, health education, and referral. This is the summary image showing the BHU population coverage, infrastructure, and services provided. Next is the rural health center. Rural health center is the primary care providing the 24-hour emergency services and limited inpatient care. It covers 30,000 to 1 lakh population, having 10 to 20 beds, minor operation theater, and labor room. Staff include 2 to 3 medical officer, one WMO, one dental surgeon, staff nurse, LHVs, midwife, and paramedical staff. Functions of rural health center are curative services which provide daily OPD for common illnesses, 24 by 7 emergency treatment, minor surgical procedure, short-term inpatient care, maternal and child health which include antenatal delivery and postnatal care, basic emergency obstetric and newborn care, and family planning services. Number third is preventive and public health which include immunization, disease surveillance, and outbreak reporting, TB, malaria, hepatitis program, health education, and nutrition council. Next is the diagnostic and the referral role, basic lab investigation and X-ray, stabilization of emergency referral, linkage to the THQ and DHQ. This is a summary image of a rural health center in Pakistan. Next, the challenges at the primary healthcare level. Primary healthcare level, insufficient participation, limited community involvement, restrict responsible to the local health needs, low utilization, limited community trust. Preventive and promotive function are often neglected due to the curative damage and weak linkage, poor connection between the facility and the outreach program. Next is the secondary healthcare level. Secondary healthcare level is a more advanced and specialized level. It usually receive patients through the referral from the primary healthcare facilities. Although many patients in Pakistan served directly, it includes Tehsil headquarters hospitals and district headquarters hospitals. The SEAL headquarters hospital is the secondary care hospital is first major referral level. It covers 1 lakh to 5 lakh people. It includes 40 to 60 beds. Staff includes specialists in discipline, medical officer and WMO, nursing and diagnostic staff. District headquarters. District headquarters is the highest level of secondary care within a district. Population covered 1 million to 3 million population. Bed include 100 to 250 bed. Specialized care are available include medicine and light specialty, general and orthopedic surgery, gynecology and obstetric, pediatric and neonatology, ICU, blood bank and diagnostic services. Staff include multiple consultants and specialists, and in some DHQs there are postgraduate trainees are also present. Services and function of DHQ: specialist outpatient services in medicine, surgery, gynecology, and pediatric, inpatient medical and surgical care, emergency and trauma services, diagnostic facilities such as laboratories and imaging, management of condition require hospitalization or specialist input, ICU and blood bank. Next is the challenges at the secondary level. Secondary hospital experience heavy patient load due to the self-referral and bypassing of primary care, overcrowding, limited bed capacity, and shortage of specialists compromise quality of the care. Diagnostic and emergency services are frequently stretched, and referral feedback to the lower level is rarely institutionalized. Number third is the specialized healthcare. Specialized healthcare is the highest level of medical care in Pakistan, which is highly specialized, complex, and technology-intensive services. Tertiary health care is delivered through the teaching hospitals, specialized institution, for example, cardiology, oncology, neurology, federal and provisional referral hospital. Services provided by the uh, tertiary healthcare is management of the chronic diseases, management of the complex and life-threatening diseases, provide advanced and diagnostic procedures, specialized care, and referral services, patient referred from the THQ and DHQs. The role of tertiary healthcare in medical education and research, training of undergraduate and postgraduate, residency and specialist training, nurse and allied health education, clinic research and innovation, development of treatment protocol and guidelines, set policies, standard guidelines for specialized healthcare and medical education, responsible for budget planning, procurement of medical equipment for teaching hospital and specialized facilities. Challenges at the specialized level are it is highly high cost, urban concentration, resource aversion, inequitable access, and weak referral system. This is the level of healthcare, primary level, which is the closest to the community, secondary, which is the more advanced level, and specialized is the highly advanced. Next is the referral mechanism in health system. The first level of contact is the primary level, which is provide initial assessment and treatment, preventive care and health promotion, and refer complex cases to the secondary level. Secondary level include specialized diagnostic and treatment, and it handle the referred cases. But if the cases are more complex, it refer to the tertiary level. Tertiary level provide advanced care and surgeries and feedback loop follow-up information sent back to the referring system. Next is the recent policy shift in Punjab. Punjab has introduced new PHC services delivery approach aimed decongesting tertiary hospital, improving first care contact, enhance accessibility to the urban and peri-urban areas. These initiatives represent a shift facility-centric PHC to the service-centric PHC. This is the emerging models of PHC, which include filter clinics, clinic on wheel, and outreach heavy service delivery. The Mariam Nawaz Filter Clinic are first contact outpatient clinic located near or within the major hospital. It is designed to screen patient, manage minor alignment, refer only genuine cases to the tertiary care. Policy intent reduce OPD burden of the tertiary hospital, strengthen gatekeeping in Pakistan. Next is Clinic on Wheel, mobile, fully equipped primary healthcare unit. It is targeted to underserved urban slum, remote rural areas, emerging and disaster setting. Its services provided by Clinic on Wheel is OPD, medicine, and basic diagnostic services. Next is the devolution of health 18 constitutional amendment. Devolution of health in Pakistan occurred through the 18 constitutional amendment in 2010 to 2011. Before devolution, health was largely a federal subject with centralized policy making, planning, and implementation. The rationale of devolution was bring decision making closer to the province, improve responsiveness to the local health need, and strengthen provisional ownership of service delivery. Health before devolution was primarily a federal subject. Federal Ministry of Health and controlled policy, planning and financing. National health programs are centrally designed and managed. Provinces mainly act as an implementing unit. Uniform policies across the province with limited flexibility. Human resource decision was centralized, weak provisional ownership, and limited local responsiveness. Health system before after devolution health become a provisional subject. Province gain authority over policy, planning, and budgeting. Provisional Health Department manage service delivery and HR, greater flexibility to address local health need, federal ministry retain coordination and regulatory role, increased provisional ownership and accountability, variation in performance across province emerged. Next is the federal law after devolution, policy coordination and stewardship, regulation of drug and medical devices, disease surveillance and health information system, implementation of international health regulation, international partnership with WHO and UNICEF, setting minimum national standards. Health and Population Department. The Health and Population Department is the primary provisional authority responsible for public sector health service delivery and population welfare services. After devolution, it operates under the provisional government and oversees planning, regulation, financing, and implementation of health program across all levels of care. Its health wing provide preventive and promotive and curative and rehabilitative services, whereas population welfare wing provide family planning and reproductive health services. Joint contribution to MNCH and fertility reduction integration mainly at the primary healthcare level. Next is the recent advances. This is the article published in 2020. Healthcare system and its challenges in Pakistan. And this paper shows multiple challenges in healthcare system program and its weakness, and also gives some recommendation to improve. If healthcare system play an important role in development of the country, if the country may want to make a progress in all the field of life, it should provide the health atmosphere to its citizen, and it only responsible possible when it is increased by the manpower system. Pakistan is in an underdeveloped country and stands in the fifth position among the 102 developing countries. It has totally taken inherited healthcare system from the British side in 1947. Healthcare system consists of private and public sector. The private sector serves 70% of the population, whereas the public sector serves as 30% of the population. According to the Constitution of Provisional Health of Pakistan, the government responsibility to provide health facility to the citizen. Healthcare services are delivered through the three-tiered primary, secondary, and tertiary. In the primary include PHU, the RSC, and secondary include THQ and district headquarters, and tertiary healthcare hospital is an individual system. Next is the review article, analysis of the healthcare system of the Pakistan. This hmm, a systematic research of national and international literature were looked from the peer database of medicine. Result are there are little strength in the healthcare delivery system in Pakistan, like making health policies, participating in Millennium Development Goal program, initiating vertical program, introducing public-private partnership, improving human resource development and infrastructure by basic health unit and rural health center. However, all the programs are limited in its scope, and that is the reason that Pakistan healthcare system is still very efficient, is not very efficient. So the conclusion of this was Pakistan is improving very slowly in the health sector for the last 5 decades, as evidenced by its health indicator and above mentioned strength and weakness. Therefore, the government need to take a strong initiative. Uh, Next is the MCQs. MCQs number one, the district report overcrowding in its tertiary hospital OPD due to patient presenting with a minor alignment, which intervention would most directly strengthen the referral chain. A, increase ICU bed at the tertiary level. B, recruit more specialists in tertiary teaching hospital. C, establish filter cleaning near tertiary hospital. D, expand postgraduate training seats. E, upgrade tertiary diagnostic equipment.
C.
Yes, C is the right option. MCQ number second. In a tehsil with a 2,50,000 population, emergency obstetric cases are frequently referred to district health quarter due to the lack of minor surgical capacity, with which upgraded which upgrade would most effectively reduce an unnecessary referral? A, add observation bed in VHU. B, strengthen labor room and minor OT in ATHQs. C, introduce more LHWs in community. D, expand tertiary ICU facility. E, increase NGO outreach program.
C.
B is the right option. Strengthen the labor room in minor OT in THQs. MCQs number three, a policy analyst observed that 73% of the population rely on out-of-pocket expenditure for health. This situation best reflects dominance of which system? A, vertical system. B, public national health services. B, C, mixed system. D, armed forces. E, social insurance model.
Charlie. C.
Yes, C is the right option. Mixed health system. MCQs number four, after devolution, variation in provisional health province performance increased. The outcome was the outcome most logically result from A. Centralization, federal procurement, B. Uniform national budgeting, C. Provisional autonomy in planning and financing, D. Elimination of vertical program, E. Reduced donor involvement.
C.
C.
Yes, is the right option. MCQ number 5. A patient with polytrauma is first stabilized at the RHC and then referred up. The reflect which essential function of primary care: A. Definitive specialist management, B. Long-term rehabilitation, C. Gatekeeping and stabilization, C. Advanced diagnostic intervention, E. Policy formulation.
C.
Yes, C is the right option. Gatekeeping and stabilization. MCQ number 6. A province introduced more mobile clinic on wheel unit in peri-urban slum, which system principle is primarily being applied: A. Centralization of service, B. Risk pooling mechanism, C. Specialist lead intervention, D. Insurance and reimbursement, E. Service centric PHC approach.
E.
Yes, yes, E is the right option. MCQ number 7. Following the 18th Constitutional Amendment, a province designed its own maternal health program based on local need. This change is mainly due to A. Increased federal control, B. Centralized health planning, C. Provisional autonomy in health governance, D. Prioritization of health services, E. Expansion of tertiary hospital.
C.
C.
Yes, C is the right option. MCQ number 8. A patient covered under employees social security receive care from only from designed ESSI hospital. This is the example of A. Mixed health system, B. Vertical health system, C. Pure public financing, D. Decentralized governance, E. Horizontal insurance policy pooling.
A. Charlie.
B is the right option. Vertical health system. Employee social security system is a vertical health system. MCQ number 9. In Pakistan, many agencies are delivering health through vertical, horizontal, and mixed system. Which of the following is provide horizontal system of health? A. Armed Force Health System, B. Fauci Foundation, C. Employee Social Security Institute, D. Pakistan Autonomous Quasi State Organization. D is the right. D is the right option. Horizontal system, Pakistan Autonomous Quasi State Organization. MCQ number 10. Despite existence of mixed health system, Pakistan has failed to achieve health for all. The failure is due to interplay of following determinant, except A. Inadequate state funding, B. Burdening and regulate role of private sector, C. Lack of transparency in governance, D. Excellence in professionalism, E. Unethical marketing practice.
D.
A.
D is the right option. Excellence in professionalism. This is the answer key. This is the reference from where I took the data. This is the YouTube channel where this presentation will be uploaded. And thank you.
Thank you very much. Dr. Rabbia, would you please stop recording?